Dr. Yasmeen Yahya, who's a family medicine consultant, MRC-GP International, who has a diploma in diabetes care and education from Dundee University, a diploma in healthcare management and quality from Guest University, currently working in Msaad Saleh Shu'ab Primary Care Center, a trainer and examiner in Kuwait Family Medicine Residency Program, a member of the Faculty of Primary Healthcare KIMS. Dr. Yasmeen, please, you have the floor.
Assalamu alaikum. Good afternoon, everybody. Thank you for inviting me to this very successful event. I'm really happy to share with you my lecture. Just have to share my slides. Okay. So my topic is about approach to tremors in primary care. And the intended learning outcomes for today's lecture is to determine the approach to tremors in adults in primary care and to review the diagnosis and management of some of the common causes of tremors that you might encounter in your practice. So, and the outline of my lecture, I will start with an introduction and then an overview of classification of tremors and some of the common causes of tremors like essential tremors, Parkinson's disease, enhanced physiological tremors and functional tremors, and lastly, how to approach a patient with a tremor in terms of history, physical examination, and investigation. So I'll start first with few videos. I would like you to see those videos and guess which type of tremors belong to each video. I will not give you the answer at the time. At the end of my lecture, I will replay the videos again and give you the diagnosis. So let's start with this first patient. What is the most likely cause of this tremor? I can't see anyone answering in the chat. Can you please answer in the chat? Just give us some guessing. Are you able to see the video or? Okay, I'll move to the other slide. What about this patient? What do you think the most likely cause of this tremor? So first, while he's pouring water, and now while he's drinking. Chat is disabled, they're telling Dr. Can you solve this, Dr. Abdullah? I don't know why the chat is disabled. If you can solve this, please, the organizers. Okay, let's move to the third patient, and I want to guess. But I'm just, okay, I would like you to guess this kind of.
Doctor, the chat is, we fixed the chat, so you can read the answers from the chat now.
Okay, good. So now, what do you think, what is the type of this tremor? Is it a rest tremor? Is it an intention tremor, postural tremor, or isometric tremor? Okay. Okay. So I've seen some some of correct answers. So I'll skip to the next patient. What is the most likely cause of this tremor? Is this a functional tremor, a physiologic tremor, essential tremor, or orthostatic tremor? Okay. Okay. As I told you, I will tell you the answer at the end of my lecture. What about this tremor? Parkinson's disease, multiple sclerosis, essential tremor, or cerebellar disease? Okay, some of you mentioned it's essential, some of you mentioned it's cerebellar. Okay, and now I think this is the last patient. What is the most likely cause of this tremor? And it's a bit longer video, maybe less than a minute, but you just observe. Okay, some of you mentioned A, some of you mentioned D. Okay. Let's move on to the lecture and we will discuss these videos at the end. Okay. Now, what are tremors? Tremors, of course, it's the most common of all movement disorders. It is defined as involuntary, rhythmic, oscillatory movement of a body part resulting from the contraction of opposing muscle groups. There are many classifications of tremors or different classification of tremors, but the most common classification is to divide them between rest tremors and action tremors. What are rest tremors? As the name implies, it occurs in body parts when they are fully supported, relaxed, and not voluntarily activated. So they're resting when the limb is resting or the body part is resting. Action occurs with voluntary muscle contraction. Action tremors are further divided into postural tremors. What does it mean? It means that when the body or when a limb is voluntarily maintaining a specific posture or a specific position, here the tremors happen. Or isometric tremors. Isometric tremors, it occurs when the muscle contraction contracts against a stationary object. Like, for example, when the patient is making a fist or squeezing an object or pushing on a wall, then the tremors happen. And then there's the kinetic tremors. Kinetic tremors occur during any movement. So when the patient starts moving his limbs, he will have the tremors. Postural tremors are further divided into essential tremor. So essential tremor is a subtype or one of the types of postural tremors. Physiologic or enhanced physiologic tremor. It's also postural tremor. And there's one entity of tremor called orthostatic tremor. This is usually limited to the legs and trunks and occurs exclusively when the patient stands for a period of time. Then he will get jerky movements in his legs. This is called orthostatic tremor. The kinetic tremors, an example of kinetic tremors are intention tremors, which happens when it's characterized by a crescendo increase in the tremor as the affected body part approaches its target. And there is also a task-specific tremor, which occur during a specific task, such as, for example, writing. So this is the general classification of tremors. Now, what are the common etiologies of tremors? In rest tremors, the commonest by far is the Parkinson disease in rest tremors. There are also other differentials or other causes like Parkinsonian syndromes and Wilson disease. Postural tremors, as we mentioned, essential tremors, enhanced physiological tremors, orthostatic tremors are all common etiologies for postural tremors. And for intention tremors, usually there's something in the cerebellum. So it's either cerebellar disease or multiple sclerosis or midbrain stroke or trauma. It's important to mention that sometimes these tremors they interchange, they intersect like happen in both. So sometimes you'll have a Parkinson disease patient who would also have postural tremor, and also in those with severe essential tremors that you will have also rest tremors, and also the same with cerebellar diseases. Sometimes they do have postural tremor. Now we'll go for the commonest causes of etiologies, a brief overview. The most thing that we'll concentrate is on essential tremor, because essential tremor is the commonest type, which we will most likely encounter in primary care, and we can manage in the early stages in primary care. We don't need to refer to neurology if we're sure of the diagnosis. So essential tremor is a common condition. The prevalence increases with age. It is slowly progressive. So this differentiates from the exaggerated physiological tremor. The physiological tremor, they don't progress. In contrary, they become better if you remove the causative agent. But here it slowly progresses. There's a positive family history in 30 to 70% of patients, and it is believed that the mode of inheritance is autosomal dominant inheritance with reduced penetrance. It is characterized by postural tremor, and also may have action tremor. So it is usually activated when the arms are held in a fixed posture. Usually when you ask the patient to stretch his arms in front of him, then the arm will start to tremor, or by voluntary movements. It's a low amplitude, high frequency tremor. So it's a bit fast tremor, and usually movement worsens the tremor. It might be improved with alcohol, and it's absent at rest. The characteristic feature is that there is always bilateral involvement, and it always starts with the upper extremities. Site of involvement, 90% patients will have hand involvement, 30% will additionally, in addition to their hand, will have head involvement, and 15% will also have tremors in their voice. But there must be a hand involvement. Otherwise, if it's only head involvement, then this excludes essential tremor. Usually it is exacerbated by anxiety, hunger, fatigue, caffeine, extreme in temperature. These factors exaggerate also the physiological tremor that we are going to talk about. The major diagnostic criteria or the diagnostic criteria from International Parkinson and Movement Disorder Society is to have these 4 features. Feature 1, isolated tremor consisting of bilateral upper limb action tremor with or without motor abnormalities. Sorry, without other motor abnormalities. Should be only tremor without any other motor abnormalities. And as we said, it should be bilateral. It should involve the upper limb. It can, with or without tremors in other locations, head, voice, or lung. Very, very rarely, the essential tremor will affect the lower limb. And it should be at least 3 years in duration. And of course, there should be, you should make sure that there is absence of other neurological signs such as dystonia, ataxia, or Parkinsonism. If these 4 features are present, then you can diagnose essential tremor. Let us take this question. or this MCQ, a 43-year-old man presents with a complaint of shaking hands that has progressively worsened over the past 2 years. His tremor is most noticeable when he's writing or using utensils, but is less apparent when his hands are at rest. His father has the same condition. So this is a classic scenario of a patient with essential tremor. Which one of the following is the most appropriate treatment option? Bisoprolol, primidone, topiramate, or levodopa? What do you think? Most of you answered A. Okay. Should it not be propranolol? Okay, at least one person is awake. Okay, I intentionally put bisoprolol because in this case the only option here, the most appropriate treatment option is B, which is primidone. Bisoprolol is actually the first-line treatment is non-selective beta blocker, and bisoprolol is a selective beta blocker. So it has no role in the management of essential tremors. So the other option, which is also sometimes indicated as a first-line treatment option, is the primidone, which is an anticonvulsant. This is the algorithm from UpToDate on how to treat essential tremors, and it depends if it is only situational, like during public speaking, or not very frequent. Then you can take the preferred option is to give a low dose propranolol, 10 or 20 milligram, taken 1 hour before the event. Okay, but if it's frequent and daily, if beta blockers are not indicated, then you should go, they're not indicated, then you should go for propranolol. And here you should give a higher dose, start with 60 to 80, and you can reach up to 360 dose. If there's a contraindication to beta blocker, then primidone is considered as a first line treatment option. So the treatment here are non-selective beta blockers, and the only one indicated that available here in our in primary care is propranolol, which is the generic name, or the trade name is Enderal. I'm sure you're all familiar with it. There is in secondary care primidone, which is called misoline. These two are the first line treatment options. Okay, we'll move to the Parkinson's disease. Parkinson's disease is characterized by rest tremor, which is usually characteristics of pill rolling tremor, but could be extension, flexion, supination, and pronation at the wrist. Usually it is slower than the essential tremor. It improves on action. They may have postural tremor as well. And of course, you all know that Parkinson's disease has also other symptoms such as bradykinesia, rigidity, postural instability, and these are the Parkinson's disease symptoms. They usually also have masked face, their stooped posture, shuffling gait, tremors in the legs, hand tremors, and all these things. This is the main differentiating features between Parkinson's disease and essential tremors. First, the age in Parkinson, usually in above 50. Here, you might have young people, especially in those familial essential tremor, at their second or third decade, who have essential tremor, and also at higher age. Usually, the males are affected more than females in Parkinson's disease. Here, it's equal. Family history is more obvious or more present in essential tremor. Asymmetry is more seen in Parkinson's disease. Usually essential tremor, there's symmetrical involvement. Frequency of the tremor here is lower, it's faster in essential tremor. The character here at rest, here it's postural or kinetic. And here the hands and legs, chin and tongue here, hands heads and voice, usually not, legs are not involved here, and usually head is not involved in Parkinson's disease. And there are also other associated features. Let's take this also the second multiple choice question. A 66-year-old male complains of wrist tremors affecting his right hand. You also note a shuffling gait and general slowness of his movements. Which one of the following is the most appropriate treatment option? Yeah, most of you answered the correct answer, which is, of course, levodopa. This is the classic presentation of a person with Parkinson's disease, and levodopa is considered the first line option in most of patients of levodopa, Parkinson's disease. It's very important that you need to refer promptly all patients with wrist tremors or those you suspect of Parkinson's disease. The management or treatment of Parkinson's disease is very complex, and usually neurologists, they have to choose from the different medications that are available, but usually levodopa is started as first line treatment in most of the patients. And this is the commercial name, Sinemet, which is carbidopa and levodopa combined. Now we'll move to the physiologic tremor. The physiologic tremor, of course, all of us have a very low amplitude physiological tremor, which is rarely noticeable under ordinary circumstances. Even if you stretch your own hands, you'll see a very fine trembling or tremor of your hands. But this could be enhanced because of increased sympathetic activity. So the treatment is just by removing the offending drug or treating the underlying cause. What are the factors that might enhance the physiological tremors? There are many. The first is thyrotoxicosis, fear and excitement, muscle fatigue, alcohol and opioid withdrawal, hypo and hypercalcemia. That's why you have to do serum calcium for patients with tremor. Hypoglycemia, anxiety, caffeine and nicotine, and certain medications, and also fever. The third MCQ, all of the following medications can cause tremors except. Which do you think the drug that doesn't cause tremor as a side effect from this list? I'm waiting for your responses. Okay. والله شطار ما شاء الله عليك. Yes. It is D. All the others are known to cause tremors. Beta-2 agonist is the most common, which is it's salbutamol or Ventolin, corticosteroids, anticonvulsants, antidepressants like SSRIs or even amitriptyline. They all, or TCAs, they all cause tremors. Now we'll go to the functional tremor. Functional tremor is previously known as psychogenic tremor, and now it's called functional. As the name implies, it's functional, so there's no underlying pathology. And that's why it is characterized by complex rest, postural, kinetic tremor, and it has abrupt onset because the cause is usually psychological. It will worsen. Usually, how do we detect it? It worsens under direct observation, and when you distract the patient, it diminishes. And it's inconsistent over time. So sometimes it's severe course, and sometimes it's not. And the amplitude is very variable. Every time the amplitude changes. So this, you would know that there is an underlying either an anxiety disorder or a conversion disorder doing this tremor. You cannot categorize it into rest or postural or kinetic. And
I apologize, Sarah Yasmeen, you have 5 minutes left.
Yes, sure. I will finish in 5 minutes. So it doesn't mean that the patient is faking the tremor. He's not faking it. It's real, and he's not aware that he has an underlying anxiety disorder. That's why you have to detect that and accordingly treat the underlying psychological disorder. Now, the last 3 slides, how to approach a patient with tremor. Of course, always start with a good history and physical exam, and maybe then you'll order a few tests. So the history, you should first clarify the tremor. You should know when was the age of onset, what body parts are affected, is it symmetrical or not, what positions will bring the tremor, is it task specific, and how is the progression? Is it getting worse by time? Is there any precipitating or aggravating or relieving factors like caffeine or alcohol or medications, or exercise or fatigue or stress? And are there any associated neurological symptoms? For example, stiffness and shuffling gait, this suggests Parkinson's disease, ataxia, dysarthria, this suggests cerebellar disease. Is there symptoms of hyperthyroidism? And then you have to go to the drug history, alcohol, family history is very important, past medical history, does the patient have stroke, multiple sclerosis? And of course, psychosocial history is very important. And how is this tremor is affecting the daily activities? And physical exam, you have to observe the tremor. You have to see which parts are involved. And you should look for head tremors and voice tremors, and ask the patient to say E and see if he has voice tremors. And then you have to ask the patient to do certain positions for tremor. First, he will rest his arms supported on his lap, and then he will outstretch the arms with finger abducted. This is classical to detect both enhanced physiological and postural tremor. You'll ask him to do finger nose test for cerebellar diseases, for intention tremor, and ask him to drink from a cup, and ask him to write or draw spirals. Both are affected by essential tremors. And you'll observe his gait, okay, and look for abnormal posture. You should also try to distract the patient and do a mental task. And you might want to do, according to your differential thyroid exam, rigidity and bradykinesia, coordination, nystagmus, cerebral disease, and neurological exam. For the investigations, you should order the routine lab, including CBC, full profile, especially electrolytes and serum calcium, liver function test, because sometimes patients with liver failure have flapping tremor, thyroid function test. And the guidelines mention that you have to exclude Wilson disease in any patient who is under 40 presenting with unexplained tremor or involuntary movement. So they usually do ceruloplasmin and 24-hour urinary copper, and if indicated, neuroimaging. So let's go to the videos again and conclude the lecture. This was the classic rest tremor in patients with Parkinson's disease. Maybe not the classic pill rolling, but you can see that it's asymmetrical, more on the right side compared to the left. And this was a patient with essential tremor. You can see that when he ever hold this posture, now this posture is maintained, he will have tremor. And also, when he holds the head, the glass next to his mouth, he's also getting tremor. So this is postural tremor. This is the classic intention tremor, because the tremor increases dramatically as the patient reaches the target. And this is usually indicates cerebellar disease. And this is a physiological tremor. You can see that there's very fine tremors. You can see at the end of, or when the hand is stretched, or when you put a paper on the hand. This is also an essential tremor with head tremor. And we said that in addition to the head tremor, there should be also tremors in the hands. So not only head tremors alone, but the patient with Parkinson would not have head tremors. And this is a functional tremor. Why? Because which we called previously before psychogenic. If you can notice that the tremor only happens with one angle, when he's asked to change the angle of the cup he's holding here, the tremor disappeared. And also, when he gets distracted and asked to wear his braces, dental braces here, and repeat the tremor also disappears. So this is classic presentation of a functional tremor in which there is variability in the tremor and sometimes it's postural, sometimes it's so. See, the tremor just disappeared. So this is a functional tremor. So again, the clinical classification is usually based on history, tremor characteristics, and if there are any associated neurological and systemic signs. And there are a number of diseases and disorders that can cause tremor. Thank you, and I wish you the best of luck in your exams.
Thank you, Dr. Yasmeen, for the sharing this wonderful lecture with us. We have time for a few questions. If you can write any questions on the chat.
I couldn't read any question. So I think there are no questions. Or
It seems that there is no questions for the informative lecture. Thank you, Dr. Yasmeen, again.
welcome.
Much appreciated for the wonderful lecture. We'll have a break until 6:10, inshallah, and then we'll move on to our next session, inshallah.
There's one question. Can I answer it, please?
Sure, of course, of course.
Are salbutamol-induced thyroxic and CO2 retention tremors all considered physiological? They're considered side effects of drugs. So they are they considered that they exacerbate the normal physiological tremor. So yes, we can broadly categorize them under exaggerated or causes to exaggerate the normal physiological tremor. MS patients, what kind of tremor? Usually if the cerebellum is involved, then it's intention tremor. And they could have, like I told you, they could have interchangeable kind of tremors. There's like no specific entity for a kind of tremor for each disease. So there is an overlap, but mainly if it's affecting the cerebellum, then it will be an intention tremor. Okay. Thank you so much, everybody.
Thank you again, Dr. Yasmeen. Just a reminder, our break will be until 6:10 p.m. instead of 6 to continue our next lecture.